Thank you so much for inviting me to this conference. Although I'm not a pediatrician, I am a medicine internist. Yeah, thank you so much for calling me. This is a vast topic. I would like to do justice to it as much as possible. It has a very special place in my heart as it was my thesis topic also. Uh, So, as we know, this is one of the smallest and the simplest bacteria. It was diagnosed during the World War II, known as the ethane agent by its nemesis, and it is found to have a lot of atypical pneumonia-like picture in the outbreaks amongst the war refugees in the World War II. Currently, it has been found to have recurring episodes and epidemics every few years. Amongst the 120 species of mycoplasma, hardly a few are known to cause human diseases. And it favors localization in our respiratory epithelium, urogenital tracts, as well as alimentary canal and joints. It is spread via human to human contact, sexual contact, and via urogenital and droplet infections. So, if we talk about Mycoplasma pneumoniae per se, it can invade and it can cause hematogenous spread and transplacental infection and causing devastating neonatal infections as well. So, let us start with a case. My apologies, it's an adult and not a pediatric case, but this is a recent case that I encountered in our hospital. So he's a 45-year-old male. He's uncontrolled diabetic, hypertensive, obese, dyslipidemic, and he presents to the emergency with history of fever since the last 12 days. So he specifically says that the fever was very high grade. He had chills, but he's afebrile since the last 2 days. He had cough, which was initially dry and non-productive. However, since the last 5 days, the cough has become productive and with copious amount of sputum, and he has occasional blood-stained sputum as well. Since the last 3 days, he is short of breath. So he was admitted in an outside hospital and he was found to have uncontrolled sugars for which insulin was started. He had an episode of respiratory distress with a lot of chest discomfort and documented desaturation up to 65%. Here, he also had an episode of black tarry stool. The primary healthcare center over there referred the patient to Gangaram Hospital, and he presented to us with labs from the outside hospital showing a drop in hemoglobin, showing elevated TLC counts, and some thrombocytosis. He was also found to have grade 1 fatty liver and a bilirubin of 5.7. My apologies, this is indirect hyperbilirubinemia. His creatinine was normal at this point. Now, when he came to us, he was pale, he was icteric, and the rest of his systemic examination was virtually general physical examination was virtually normal. His oxygen requirement was 4 to 5 liters, and he was very tachypneic and tachycardic. Respiratory examination, he had diffuse wheeze. He has fine creps. However, rest of the systemic examination was fine. So the labs that we did at our emergency showed that the hemoglobin further dropped from 10 to 6.7. His platelets were continued to rise and his TLC count was 25,000. His MCV, MCH, MCHC, they were all deranged. We sent a sputum sample for this patient. However, it just grew mixed flora and no pathogenic organism. Gene expert was negative. His CRP was highly elevated. Procal was negative and ESR was elevated. Here, a peripheral smear showed some anisocytosis, normocytic hypochromic cells, some polychromatophils, and an occasional spherocyte. His anemia profile had an elevated ferritin. However, as the patient was not very sick, we did not think in the tunes of HLH. He had elevated reticulocyte, and his direct Coombs test was positive. This was 3 plus significantly positive. We followed him up with monospecific Coombs test, which showed C3D positive. Here we look at the chest X-ray of this patient, and essentially we do not see any consolidation. However, there are fine reticular nodular opacities that can be demonstrated. We've performed a respiratory biofire in which we detected Mycoplasma pneumoniae. So here we are looking at a case who had Mycoplasma pneumoniae to begin with and probably has led into autoimmune hemolytic anemia as a complication of Mycoplasma. So reviewing Mycoplasma, we have approximately a lakh of hospitalizations in adults in US. However, in children, the trend has been rising. So if we look at the incidence under 16 years of age, it's almost 9%. And between the age group of 5 to 14 years, where they have a lot of school outbreaks, the incidence of Mycoplasma pneumoniae is as high as 14%. Contributing to almost 10 to 40% of community-acquired pneumonias in closed populations and outbreaks and epidemics, it can contribute to almost 70% of community-acquired pneumonias. It can cause self-limiting to life-threatening diseases. In kids less than 5 years, usually it causes wheeze and coryza, and frank LRTI is relatively uncommon. However, between 5 to 15, bronchopneumonias are very common, and they often require hospitalization. In severe cases, they can present with bronchiolitis, pleural effusions, lung abscesses, and even pulmonary embolism. And as often as more than 50%, they have superadded bacterial infections. It is very interesting to note that there is a relation with COPD and asthma with mycoplasma. So the lung microbiota seen tested in amongst the COPD patients, they had a lot of mycoplasma pneumoniae. Mycoplasma is also responsible for acute episodes as well as recurrent episodes and acute exacerbations of both COPD as well as asthma. Uh, if we look into the pathogenesis, so there are direct mechanisms and there are immune mediated mechanisms, both of which are acting and contributing to life threatening disorders. So amongst direct mechanisms, we have invasive properties, we have toxin damages. Amongst the immune mechanisms, we have humoral as well as cell mediated immunity, both getting knocked off. The patient can present with thrombosis, vasculitis, and severe cytokine storms. So it has a special membrane interactions with our respiratory epithelium, and TLR2 mediated cytokine storms are very common. Almost 25% of the patients experience extrapulmonary complications. So this is something that is very alarming, and this is something that we must look in deeply. Extrapulmonary manifestations are usually immune mediated and are antibodies which get developed against the glycoprotein antigens of the mycoplasma. They cross react with either RBCs, causing hemolytic anemias and various hematological disorders, or with brain cells, causing a lot of CNS complications. So, RBC membrane antigen I is the one which cross reacts with mycoplasma pneumoniae, causing autoimmune hemolytic anemia. A few words about autoimmune hemolytic anemia. So other manifestations are also thrombocytopenia and DIC, which can cause catastrophic events in a patient. And these are triggered by lower temperatures, hence they are called cold agglutinins. And lower temperatures in the extremities, for example, in developing shock, they precipitate complement-mediated hemolysis. So cold agglutinin antibodies, they've been observed in barely 50 to 60% of the patients. What does that mean? That means many are missed, but also it has been documented that this causes subclinical hemolysis in even mildly symptomatic patients, and they have been found to have elevated reticulocytes. So, early pickup of subclinical hemolysis can take us far away from a devastating complication. So, what is the treatment? We have to keep the patient warm, and the blood transfusions have to be typically done in a blood warmer. Steroid therapy has not been very variedly treated for cold agglutinins hemolytic anemia. However, it's been advocated for warm agglutinins hemolytic anemia. In cold hemolytic anemias, it has been tried. However, there are no RCTs or guidelines as to what is the dose and for how long do we have to monitor. What are the CNS manifestations? However, they are as frequent as 25%. They can be very life-threatening, ranging from aseptic meningitis to encephalitis to meningoencephalitis. They can be varied complications. They are usually between the time period of 2 to 14 days from the onset of respiratory complications. However, they can be even before or much after the actual respiratory complications. It has been postulated that direct invasion of the bacteria and immune mediated, both the hypotheses are contributing to this illness. There are dermatological manifestations as well as non-specific GI manifestations that these patients can have. So if we look at the radiological features, we all know that this is atypical pneumonia. So what does atypical pneumonia comprise? It basically means that there is interstitial inflammation, which is not typically demonstrated as a consolidation. So our chest X-ray will have interstitial infiltrates. It can have alveolar infiltrates and some amount of pleural effusion. Whereas CT findings are most frequently found to be as bronchial wall thickenings. central lobule nodulus, and as we know as ground glass opacities. So these ground glass opacities should prompt us to diagnose atypical pneumonias and think in tunes of mycoplasma, EBV, CMV, Legionella, chlamydia. This should direct our empirical therapy. However, we must think before giving a broad spectrum antibiotic cover if the patient is not very symptomatic. Now I take us to this case 2. So this is the patient that I saw in my first year of residency. He was a 21-year-old, very shy male. He had some anorectal malformation and he had a solitary kidney. So he presented to the emergency with fever for a few days, hematuria, and decreased urine output. He also had left side testicular pain, which he was very shy to show to me. And he had perurethral discharge in the last 2 weeks. He was admitted in multiple hospitals in the last 2 weeks, and he was treated with all kinds of antibiotics, thinking that it's UTI. In emergency department at AIMS, he was also given multiple doses of ceftriaxone and piperacillin tazobactam. On examination after admission, he was pale and he had right flank tenderness. He had anemia, his counts were normal, he had severe thrombocytopenia, and he had azotemia, and his creatinine was 6. So here on evaluation, he was found to have full field WBCs. He clearly had pyuria, he had RBCs, he had protein. However, his culture repeatedly was sterile. This patient grew Mycoplasma hominis. Here, what I'm trying to emphasize is that sterile pyuria can be a cause for not just tuberculosis, but in our country, we must also look at mycoplasma, genital mycoplasmas as well as chlamydia. These organisms are often undetected, and these can often be misinterpreted and confused with the normal bacterial UTIs, and the patients are given truckloads of antibiotics, which lead to further difficult in culture growth. This patient had hydrouretronephrosis, he had Foley's catheter in situ, and he had chronic cystitis. So what are the genital mycoplasmas and why are they so common? So in a general population, we are not even talking about patients with STDs. They are as common as almost 4% in developing countries. Uriplasma, mycoplasma, and mycoplasma genitalium and hominis, they are spread by sexual route, but they also have a lot of further complications. For example, uriplasma can cause urethral and gynecological infections. There was a meta-analysis that was recently done which found that genitalium and hominis, along with uriplasma urolithecum, are very significant causes of infertility amongst the men. They can invade the vagina of pregnant women and translocate to the fetus and cause severe complications such as neonatal sepsis and meningitis. Hence, undetected mycoplasmas, genital mycoplasmas, can cause very catastrophic events in our unborn fetuses as well. Mycoplasma genitalium is very notorious, very resistant to antibiotics, and very difficult to treat and to be controlled. It is often found amongst the MSM population, hence, it is difficult to take history. So, the case that I was referring to was very shy to me in front of me, but then I sent a male colleague of mine and he took history and he was an MSM. That is where that he was getting repeated infections and he was shy to declare it to his family. So patients can be asymptomatic and hardly 10% are symptomatic. That's when we miss the diagnosis. And amongst the long-term complications amongst female, it can lead to PIDs, spontaneous abortions, preterm deliveries, and infertility and whatnot. Amongst men, it can cause urethritis. Almost 40% of non-gonococcal urethritis and recurrent urethritis are contributed to mycoplasmas. As I mentioned, sterile pyuria, as we evaluate in our
5 minutes left.
Yeah, I'm almost done. If you look at sterile pyuria, it is one of the undetected entity, and genital mycoplasmas must also be looked up. So it is a diagnostic challenge. We know it's difficult to culture. Culture methods are hardly available in most of the labs. It has good specificity but hardly any sensitivity, and it is almost redundant. If you look at PCRs, they have high specificity, they're expensive, but these days we have a lot of multiplex PCRs, like I mentioned, one of the respiratory panels or the genital panels that we are having, which have very good pickup rates, but they are sparsely available in public health centers. So what the most common used methods are the ELISAs, the serological methods, but downside of it is that we require seroconversions and a fold increase to actually demonstrate mycoplasma. These are very non-specific and they have a downside in form of that these either they are in the form of IgM and IgG combined test or they are rapid kits of IgM. So we need to be very careful before interpreting. IgM kits can actually give us false positives. So detect the they can basically detect a previous infection, as the IgM antibodies can last several months. Talking a few words about cold agglutinins. So they appear within the first week or by the end of the second week, and they disappear after 2-3 months. They have very good pickup rate, but they have false positives with EBV, CMV, Klebsiella pneumoniae, and various other autoimmune disorders. There are multiple rapid diagnostic tests that are available in the form of LAMP and in the form of immunochromatographic assays. These lateral flow assays have become recently very popular. They have very high specificity but low sensitivity. So as clinicians, we must be aware of the false negative results that can often be there. So how do we manage? Do we need to manage all Mycoplasma pneumonia infections? No, as they are very low mortality and they have often self-limiting. However, we can get confounded as superadded secondary bacterial infections are very common. So amongst the available options, we have fluoroquinolones and macrolides. Fluoroquinolones are the ones which are actually bactericidal, whereas macrolides and tetracycline are bacteriostatic. But if you look at the children population, macrolides are even regarded as safe in regardless of their age group because of the potential side effects of tetracycline and fluoroquinolones in the younger age group. It is important for us to understand this upgrowing resistance to macrolides abuse in amongst the mycoplasmas. So there are multiple outbreaks that keep happening. Patients have prolonged carriage, as well as the primary infection does not mount to immunity. There was a recent global surveillance data that I think ma'am was mentioning that was published recently in Lancet that actually found out that because of precautions that were taken during the pandemic and because of the masking, there was a drop in the mycoplasma rates. However, there was a re-emergence despite of discontinuation of the respiratory precautions after a very long time. This is a very difficult and a very epidemiologically challenging condition in which the rates fall down and again a disease has re-emerging. So we are also noticing a lot of macrolide resistance. The population that was studied for macrolide resistant has been growing over the years from a proportion of 18% to almost 76% in 2019. And this is all because of abuse to macrolides. For any simple URTI, everybody pops in a azithromycin. So if I follow up the cases, the first case who was a male with autoimmune hemolytic anemia, he was transfused with 3 PRBCs through a warmer. He was given pulse dose of steroids for 3 days followed by a tapering dose. He was given azithromycin along with piperacillin, tazobactam, and allicin because he had superadded bacterial infections. And within 1 week of hospital stay, the patient was discharged and following up in the OPD. The case 2, the 21-year-old male with Mycoplasma hominis, he was treated just with doxycycline, and he had resolution in his pyuria, he had resolution in his lower urinary tract symptoms. He was not given any further antibiotics. So my take-home point is that Mycoplasma pneumoniae produces a wide variety of spectrum of diseases, and extrapulmonary manifestation is something that we must all look out for. These are very common, almost as high as 25% of the patients can have them, and we must treat early in such cases. Genital mycoplasmas are very difficult to identify and they're often undetected, leading to a lot of complications in the future. We must all actively look out for such symptoms and identify them early. Resistance is a very growing concern. Hence, if a patient who is not responding to macrolides, resistance testing must be sent out for. All alternative therapies must be initiated immediately. Vaccines are under development. However, they are very, very far from satisfaction and there is not much efficacy in the vaccines. So clinical and radiological detection remains a cornerstone for our clinicians. Thank you so much.